Clinical Liver Diseases video series. CLD is one of the official journals of the ASLD. I am Shenoy. I'm one of the GI fellows at the University of Michigan, author of Anticoagulation Management in Patients with Atrial Fibrillation and Cirrhosis, and I hope you enjoy. So I think what makes weighing the risks and benefits of anticoagulating patients with cirrhosis particularly challenging is that, patients with cirrhosis have a rebalanced and complex coagulation system and an inherent increased risk of bleeding and clotting because of this mechanism. And this rebalanced or changed kind of thrombosis and hemostasis risk is the key issue. In particular, with patients with atrial fibrillation, we have these scoring systems out there to mitigate stroke risk, such as the CHADS-2 VASC, and to mitigate bleeding risk, such as the HAS-BLOOD score. However, these scoring systems have not been validated in chronic liver disease, and in fact, a lot of the randomized control trials that were used to kind of validate these scoring systems oftentimes excluded patients with cirrhosis, which makes this even more challenging, because now we have validated scoring systems for other populations and subgroups, but not for high-risk cohorts like ours. Vitamin K antagonists, such as warfarin, have been used for a very long time in patients with cirrhosis, making it one of its advantages. Some of the disadvantages of vitamin K antagonists include frequent INR monitoring, together with a patient with an elevated baseline INR, making it that much more challenging. There's been an emergence of direct oral anticoagulants, or DOACs, such as apixaban, edoxaban, dabigatran, which have been growing in its number and growing in its use among this high-risk cohort. A lot of the early studies are smaller and haven't, and though they've kind of compared, DOACs with vitamin K antagonists, the studies are generally smaller. They're not randomized control trials, and a lot of the information extracted from them are difficult to extrapolate. There has been a suggestion that direct oral anticoagulants may have a slightly lower bleeding risk than vitamin K antagonists. There are limitations of these studies that I kind of just alluded to, but at the same time, a lot of the studies have not included patients with child-diffuse C cirrhosis, which makes it difficult, to extrapolate to all patients with cirrhosis. Some of the advantages, however, of direct oral anticoagulants include fixed dosing, and the lack, of INR monitoring, for example. And its, relatively weak effect on the INR actually makes it sometimes easier for the clinician to understand a change in synthetic function, for example. So some of the takeaways from this article include, 1, even among studies with patients with cirrhosis, anticoagulation has a clear benefit in reducing stroke risk. Keeping that in mind, among the literature that's out there already, Child-Pugh B and Child-Pugh C patients with cirrhosis are at certainly a higher risk of bleeding, and this needs to be thought about before starting a patient on anticoagulation. And the last thing is that, every patient is different. Individual assessment on a case-by-case basis, together with a multidisciplinary kind of collaboration, sometimes involving a hematologist, may be helpful in certain cases. Mitigating the bleeding risk is always challenging, but I think kind of thinking about what the patient desires, what the end goal is sometimes helpful in kind of figuring out what the best thing for the patient is. For more information on anticoagulation in cirrhosis or coagulation in liver disease, please visit us at www.cldlearning.com. Thank you for watching.